you know that out of the types and the causes of ischemic stroke. So what are the causes of the hemorrhagic stroke? Yeah, trauma for sure, yes. What else? That's the easy way out. What else? Huh? Aneurysm, very good. This is called a subarachnoid hemorrhage. You get a stroke. So that, the most common cause of a non-traumatic hemorrhage is an aneurysm rupturing. Okay, so that's one. Okay, and what are the other causes? So people, who, as you get older, your blood vessels get kind of, it's like lead pipes. You know, pipes get, in your kitchen and all that, they all get, for years and years, you use all the calcium collects on it, and they get kind of, the same thing happens in the brain when you have diabetes or hypertension. Your arteries that were very pliable and flexible now become stiff, and and then what happens is they get blocked, and then you get a thing called a hypertensive bleed, where they're not flexible and the arteries kind of break and leak into the brain. So the most common cause is trauma. Second is subarachnoid hemorrhage. Third is hypertensive hemorrhage. And then you have other rare causes like having abnormal connections. Once again, drugs, cocaine gives you a hemorrhagic stroke, and things like vasculitis. But we won't go into that. These are the major, So now you know the two different types of strokes, and you know the causes of the two different types of strokes. All right. So now, what is the? So if you see someone having a stroke, what are the signs and symptoms of a stroke? Fast, okay, but that's not all of it. So what is it? What does fast stand for?
Can't smile on the side of your face.
Yes.
Can't hold one of your arms upright.
Yes.
I read it.
Very good.
And I didn't know all that stuff. I was glad I
That's F-A, what is S?
Speech.
Speech.
Speech, that's right. Ask them a question and have to
And then what is T?
T.
Fast, right? F-A-S-T. What does the T stand for?
let's see what.
Face, arm, speech, and time. Yes.
Oh, time.
Yeah.
Okay.
So those are the things. So that's very basic. So any changes that you have in stroke have to be acute. Okay, they don't have to acute in the sense they have to be immediate. So it's not like, oh yeah, I've been stuttering for the last 5 months or something. That's not. It's got to be suddenly somebody's absolutely normal, and then suddenly they give you this blank look, and they can't move their arm, or they can't feel their arm, or they suddenly can't talk, or they're staring at you and they can't express themselves, or they have visual problems in one eye. And most of the symptoms are usually one-sided. There are certain strokes that give you bilateral symptoms, but most of the time it's just one-sided. So that's something you're looking for. Acute change in sometimes the worst headache of your life would be a sign for a hemorrhagic stroke, not an ischemic, but mostly a hemorrhagic stroke. So we did the types of strokes, we did the causes, we did the signs and symptoms. Okay, so how do you diagnose a stroke? So when Richard comes, you guys know everything. Huh? How do you diagnose a stroke? How do you make a diagnosis?
Do the fast thing.
MRI.
MRI, one, yes. But when you go to the ER, they don't do an MRI right away. What's the first thing they do whenever anybody goes there?
I think they do the fast thing.
Yeah, the fast is now, okay, we did the fast, we know you're getting a stroke. Now we have to do some studies to confirm that you're having a stroke. Because you could have arm weakness or speech problems because of 10, 15 other reasons. They could be because your blood glucose has gone down, or you're diabetic, or for hundreds of different reasons. You might have an infection or whatever it is. But you want to make a diagnosis of stroke. So the first thing they do is they do a CT scan. So you go into this, donut-like machine. You go and you get a CT scan. What does the CT scan tell you? One thing, very important thing. It tells you whether you've had a bleed or not. It doesn't rule in a stroke or rule out a stroke, but it rules in a hemorrhage. Then you know that you got 20% strokes are because of bleeding, so at least you got that diagnosis. Now if the CT scan is negative and you still have symptoms, and you do other tests that you want to look at the blood vessels. So you do a thing called CTA or CT angiogram, where you inject dye into the arm, and then you look at the blood vessels in the brain, and you can see any big artery that's blocked, you won't be able to see it. Okay, so that's the second thing you do. Then the third thing you do is once you get the blockage, that isn't enough, right? You want to know if the brain is still salvageable or not. There's no use saving somebody whose brain's already dead. It could cause more problems. So then you do a functional test like a CT perfusion or MR perfusion, and that'll tell you how much of the brain is viable and left to salvage. And that brings about the urgency of getting things done. So you do a non-contrast head CT and a CT angiogram, CT perfusion. Sometimes they do Doppler studies in your neck just to see if your carotid arteries are open. And then you can do, but these are the, and a whole bunch of blood tests. So once you made a diagnosis of stroke, now what do you do? Huh? Yeah, try to treat it. So how do you treat it? If there's a bleed, yes. So if there's a bleed, it's not bleeding right in front of the eyes because then he'll be dying, right? So he or she. So the blood is there. You got to find out what caused it. So if it was an aneurysm, then you take the patient up and do an angiogram to see the aneurysm. And then there's two ways of treating it. One is you can treat it in a minimally invasive fashion by taking and putting coils of the aneurysm from your groin, or you can go to surgery and open the head up and put a clip across the neck of the aneurysm. But 80%, 70 to 80% of the aneurysms are treated in a minimally invasive fashion these days. So that's one thing. Yeah, that's okay to do here. So, all right. So, yeah. So okay. So you did the. So what's the? How do you treat an ischemic stroke? You need to get the blood back into the brain, right? So it's blocked. So how do you if you had your pipe in the kitchen today, it's blocked, what do you do? You do two things. You either try to put the Drano in there and see if it works, or you take a brush or some kind of a wire and you try to get all that hair out, right? So
They use the like balloon catheter.
you can do that focally, but that's usually done not in the brain because those are too big. The device is big. So what's the Drano? Anybody knows what the medical for Drano is? So it's called TPA.
TPA.
Tissue plasminogenic antigen. It's a clot-busting drug that's given intravenously, and it should be given within 90 minutes. And certain studies that have shown that we can extend the time window up to 4.5 hours now. So 3 hours for sure, in some cases up to 4.5 hours. So now you have this much time to get to the hospital and get. So if that doesn't work, and it's 4.5 hours over, it's not 5 hours you're coming to the hospital, what can you do?
You want to redirect the blood flow?
Yes?
Around the clot?
Yeah. So you want to pull the clot out. So then you go in with either a hollow tube, and there's some animations here that we'll show you in a second. And then you can suck the clot out, or you go in with a stent and open the stent and pull the clot out. So it's called mechanical thrombectomy. Chemical thrombectomy is using TPA, the drug. Mechanical thrombectomy is using a device. Okay? Then you pull the clot out, and hopefully you've done it in a timely fashion. And then the next stage is recovery of the patient, and the patient's in the ICU. And then you got to worry about all the things that could go wrong with the patient, all the complications. But that's a different topic altogether. And then this, for hemorrhagic stroke, you pull it out. So now we went through 5 different things. Okay, we went through, ischemic, hemorrhagic causes, diagnostic testing, and then the treatment for stroke. So how many strokes happen in a year in the United States?
A lot.
You know, but how many? Huh? So this,
It's like one every
how many people
7
are there in the
years.
United States? There's about 300 million people in the United States. 300 million people live in the United States. Okay, from the last census that they did. We're not talking about illegal immigrants. They were only about so, yeah, like in Chicago, there's at least 20% unaccounted. So out of 300 million people, 5% of the people have an aneurysm.
Wow.
So that makes it, at least about 5 to 8 million people harbor an aneurysm. So there's 100 people in this room. 5 of us have an aneurysm and we don't know about it. It doesn't have to be this 100 people, but just generally speaking. So how many people get a stroke?
Out of that.
800.
No, this is now ischemic stroke. Out of 300 million people in the United States, how many people get a stroke? So it's about $800,000 strokes every year.
No, the answer's in that.
I got eyes in the back of my head. I got eyes in the back of my head. And you know what? If you see a slide of mine a year ago, that number would have been what? Less or more?
More.
Less.
Less.
Because every year it's going up. By the year 2025, they predict how many strokes per year in the United States. 1.2 million new strokes every year in the United States. So as long as we keep having more and more McDonald's and more Wendy's and more this, we're going to have more and more strokes, okay? unless they start serving, big fish and salads. So the stroke numbers are going up. So now we have to really educate ourselves, because heart attacks are going down or stabilized. Strokes are still going up, right? Cancers are, certain cancers can be cured. Others, no. But all right. So
Okay, hold on. Just something new.
okay, there it is. Go back.
Where?
No, back to the brain. All right. So this is all the different things that are telling you in the brain that you have. So you have all these different centers in your brain. See, in the back of the head is vision. Okay. All right. Over here is language and it's reading. Over here is hearing. Over here is smell. This is speech. Motor control is moving your arms and legs. Touch and pressure, taste. So depending on when you have the stroke, you're going to manifest. That's why we can clinically tell when someone comes up with clinical symptoms as to where exactly they've had a stroke, okay, most of the time. All right, so these are the things you were talking about, questions. So height, blood pressure. So there are two, there's, to prevent a stroke, there's some modifiable things that you can do. That you can change your lifestyle, that you can control your high blood pressure, you can, stop smoking, you control your diabetes, control your, the plaque in your carotid artery. If you have atrial fibrillation, you can take the medications for it, that'll reduce it. Cholesterol. Stress doesn't cause stroke, but stress causes other things that, could cause your blood pressure to go up, that could cause a stroke. PFO that I talked about, and then physical inactivity. That's one of the most important. What kills you these days is, as you get older, there's two things that really said about a lot of things. There's two things. One is physical, when people don't move around, physical inactivity, and the second is depression. Those are two things that you don't die because of those two things, but those two things make everything else so much worse that's probably what gets you. All right, so there's things that you can't change, is you can't change your age, right? So, if you're 30 years old, the risk of you getting a stroke is much lower. 85 years old. Family, we talked about genetics. Race, certain races, that's also genetics again, that have a higher risk for strokes. Now, if you go to China and, there's how many people live in this world?
6, 7, 9.
Billion.
Yeah, that's what I said.
Yeah. 5 billion, 6 billion people live. Out of the 6 billion people, 3 billion are living in India and China, okay?
Yeah.
Or 2.5 billion, 1.2 billion in India and 1.4 billion in China. So half the population is living there. So what is the most common cause of stroke in China today? It's not the same reason it is over here. Here the most common cause is heart and the carotid arteries. Huh?
Would it be air pollution?
No, it's intracranial stenosis. They have narrowing in their arteries in the brain. So if you go there, they name that. Even in the United States, it's only 90,000 strokes a year is because of narrowing of arteries in your brain. While in China and those far eastern countries, it's the other way around. 90% of the strokes are because of narrowing of the arteries in your brain. And then you can't change that, right? And then if you've had a previous stroke, the chances of you getting a stroke will be much higher than if you've never had a stroke. Right?
Oh, sorry. We talked about that.
So this is it, right? We got the answers here. Ischemic, hemorrhagic, we went through that. We talked about subarachnoid hemorrhage, intracranial bleed. You guys can give this talk now. So these are all the different tools you have, to take care of stroke. So up to 3 to 4.5 hours is intravenous TPA. And then you go up to 8 hours, you can use Mercy retrieval device. We don't use that anymore. This came out, I used the first one in 2005, but in the last 2 years I've not used it because there are other devices that are now much better than that. We still use the penumbra system, we use the stent retrievers. Then up to 24 hours we have a trial that is happening worldwide, and we are one of the few centers in the United States that's in a trial. We take a little stimulator and put it in your mouth, and it stimulates the ganglia in your mouth, which actually causes your blood vessels in your side of the brain you've had a stroke to actually relax and open up and dilate. So, and then that would, help, prolong the tissues, and give them oxygen so that they don't stroke out. So, it's called the BrainScape trial. Next slide. All right, next one. So these are all the different tools, CT perfusion, MRI, angiogram, okay? So that's the CT perfusion. So look at this, So it's so easy now to tell if someone had a stroke or not right away. So you're looking at the brain, okay? So this is the same brain, but there are three different things you're looking at. You look at this picture over here, it shows the amount of blood flow that's flowing, in the brain. This one tells you how much of the blood is staying in the brain, or the blood volume. And that one tells you how long it takes for the blood to get into the brain and come out. So next slide. All right, so you looked at the one before, now look at this. You want to guess which side the stroke is? This is the left side, and this is the right side. So which side is it, left or right? Left side, here? This side or this side? Blue or red?
Blue.
Blue, yeah. So, blue is, so even, when I first started doing this,
That's what I was saying.
my daughter was, I think, 8 or 9 years old, and I'm sitting in my study and looking at these images, and she walks by and says, "Hey, Dad, got a stroke there." I said, "Yep, very good." So everybody can, so you can see how clearly blue is bad, D is bad. So you can see clearly, someone's had a stroke. This shows minutes after you've had a stroke. You can see that. All right. Next. So these are once again all the different tests to figure out. So these are all the different treatments, that we talked about. So this is the device that we put in to suck the clot out. So this is an animation you'll see right now.
I don't know that it's gonna work. Nope.
So you don't have the.
I got them separate, yes, of course I do. Sorry, guys, please bear with me. No, I'm not. I can get them online if you want that.
You can see the rap video.
Oh, yeah, I can do that.
So some of the hospitals, we made a rap video for stroke. But there's another hospital, the University of Alabama, that has a much better rap video than we did. The one we did, I was dark later, so I don't like that one. But you look at the one done in Alabama, and it kind of tells you the whole, seriousness and the comedy about stroke. If you can get it online. What are you guys doing? Some studies on strokes, or anybody doing anything?
We're nursing students.
College, huh?
Nursing students?
Nursing students, okay, well, that's good. Good profession to be in. Now, stroke is very nursing. For me, I'm a big proponent of nurses driving stroke because the factors, so many, is recognizing the patients, being with the patients, the family, after they get discharged, follow-up of the patients. Doctors can't do that. Doctors go there and they actually just do that medical, emergent part of it and then, step back. But the whole stroke, otherwise, I feel should be managed by nurses and nurse practitioners.
Oh, I'm so glad you came out today. Are you Dr. Burgess?
No, I'm Dr. Shownkeen.
Shownkeen?
Yes. He's supposed to be coming here, but he just finished a case. He's on his way, so I'm kind of just.
Well,
I'm doing a guest appearance.
I don't know either, but I don't feel like we.
I'm his boss, but it's
You
okay.
sure have
Yeah.
answered a lot of questions for us. Did a good job as far as I'm concerned.
All right. This is really exciting. You want to listen to this. How you can do magic there. There's Dr. Burgess. See? Speak of the devil. There he is. So they're going to teach you a little bit about stroke now, Richard.
Sounds good.
Do you think I'm kidding? Ask them any question. Ask them a question.
All right, well, so one question. So as far as the audience here, how many know somebody, have a family member, a friend, personally, that's had a stroke? Okay, most people, great. Okay, hopefully most of you haven't had strokes. All right. So questions, concerns? So I'm going to try to talk about a little bit about sort of modern diagnosis of stroke. But if people have any things, particularly.
They're going to see a rap video and then.
We're going to watch that.
All right. Thank you, everybody. Bye.
do their part, and we can do it because we're next smart. You can give me five, or use them class, but you better do something and do it fast. Call a coach, stroke, get an HCT. Check upstairs to make sure there's no bleed. Cool, give TPA like you should, and yo, you better push it, push it real good. Yo, it's getting better, we're almost there. Throw your hands in the air like you don't care. Oh, wait, is it worse instead of better? All right, people, we gotta fluctuate. Get to IA, the time is free. Hit the clock, no mercy is the name of the game. 7 alarms sound and make the clock bust, or you can suck it out with the bus. We can place a stake to protect the flow. Gotta act like you know, so yo, here we go. I ain't afraid of no stroke. 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 Yo, get to the stroke unit, it's a whole different universe. Bitches doing good, going bad and worse. There's a cooling catheter from hypothermia. There's a hemi-green ectomy and a patient with apnea. A man ICH with blood in his head. This was laying in the bed with a drink and a bed. Patients walk in the unit with his hopes up. They don't have dysphagia. He's all choked up. The nurse is pulling the sheet. They're going to help him with grief. The nurse is giving a laxative for patient's relief. The best check and jury documentation of these sound. Cause they know drug commission is moving around. You better cross the T's and dot those I's. You have to comply or your program's on cry. Anyway, we're finally here. Rise the bed back. They should have put in a Foley, I bet. Would keep the BPM and something else too. You better get some expert up the wazoo. A cardiac monitor, echocardiogram, MRI, ultrasound, a cerebral angiogram. And some days in he's better. A big turnaround is over service involved because he's homeward bound. Now it's time for rehab. Yo, there's still hope. And now we can say, what? I ain't afraid of no stroke. If someone has a stroke and the brain goes numb, who you gonna call? 911. Where they gonna go? Here's a hint, sir. Who you gonna call? Stroke center. When he gets there and you see he's no joke, who you gonna call? Code stroke. We need a diagnosis, folks. We have to have a plan. Who you gonna call? CAT scan. If there's no bleed, don't get flustered. Who you gonna call? Blockbuster. To make sure everything is going well. Who you gonna call? Intervention now. Everything's going good. There's nothing to it. Who you gonna call? Stroke unit. We need to fix his speech symptomology. Who you gonna call? Speech pathology. To make sure he's leaving with a purpose. Who you gonna call? Social service. The patient's better than what's back what he had. Who you gonna call? Rehab. Give me an F. A. S. T. Fast.
Who's afraid of the big bad stroke? The big bad stroke, the big bad stroke. Who's afraid of the big bad stroke?
So that was our little bit of fun for you.
So I think that there's lots of great terminology in there. It's sort of a fun talking about all the various things that we do. I think the most important thing about that video is the way that it demonstrates the team approach. There are a lot of people in that video. There are a lot of people involved in touch any patient who has a stroke and comes into the hospital. From the EMS to the triage people, or the ER nurses to the ER doctors, CT scan, X-ray, ICU nurses, floor nurses, doctors, both neurologists, medicine doctors, cardiologists, interventionalists, all sorts of people. So it really is a sort of a team approach because there's a lot to know and a lot to be expert in. So hopefully we'll just sort of go over some basics. We'll go over a case, I think. Yeah, we have a case here. Great. We'll go over a case that sort of touches things. So here we have not a atypical patient, a 58 years old woman, had right-sided weakness and trouble speaking. That would be a classic stroke, that we'll call aphasia, and right-sided weakness. The NIH stroke scale, which is a scale that we use to sort out how bad somebody's stroke is, anywhere from 0 to roughly 40, but mostly in the single digits and teens, with 17, so a pretty high scale, a bad stroke. And the key thing here is the last known well is not known. That can be a problem. It's really important to know if someone's had a stroke. when it started. Very good, thank you. All right, so this is the first thing to do. I think Dr. Shownkeen showed you a perfusion scan. This is on the upper left, a regular CT scan. And we can see in the upper left there a little white spot circled with the red circle.
Can everybody hear Dr. Burgess okay, or do we need to put a mic on?
We need a mic.
Just turn it on.
Hello? Is it recording?
Okay, try it.
All right, how's that? What would I do without this?
I don't know. Wow.
So regular CAT scan, a big circle around a white splotch. And that could be a couple different things on a head CT. In this particular case, I look at the perfusion, and I'm looking to see whether there's a difference in the two sides. And certainly, if you look at a couple of these scans, you see something is different over here, different than all of this. And that makes me suspect, as I look at this, that there is something in this artery, the artery that goes to this area, closing up, a clot perhaps. Sometimes those will show up white on the scans. So the CT doesn't show any evidence of hemorrhage, but it shows this large area with not enough blood flow from the left side of the brain. Of course, the left side of the brain controls the right side of the body and has speech in most people. And so that fits with the patient's symptoms of right-sided weakness and trouble talking. This is the angiogram. So one of the ways to look at the blood vessels in a patient is with a cerebral angiogram. It's similar to how you might do a cardiac angiogram. The basics are that we put a tube into the blood vessel that runs it in, and we inject dye. That dye shows up on the special X-ray camera that we use. And by doing some tricks, we can remove the skull and all the other things and just see the blood vessels. And that's what we have here. There's the tube is right here, injecting dye up into the left internal carotid artery. You can see it go up, and the skull starts about there. The blood flow into the skull, and then into the brain. It's going up to the middle of the brain, up to the right side of the brain. It's supposed to be going up and like this, just the way this goes up. There's supposed to be the same thing over here. It's not. This blood vessel is cut off right about here. There should be lots of blood vessels right in here, and they're not there. There's a clot sitting right here. So it mentioned in the video, using a Hoover. In this particular case, another little tube was manipulated to right here, and suction was applied, and the clot was sort of sucked into the catheter, which was then removed. And then when they took another picture, you can see that there's blood flow out to this area. It was cut off right there, and now it's all going here. And again, on this picture, you can see that there's blood flow to that blood vessel. You might wonder what's going on over here. That looks a lot different than it did. We used to have all of this. And the main reason for that is just pressure. Because the blood couldn't push out here, it had to go somewhere, so it actually went across and went to the other side. Normally, the other side is actually supplied by a blood vessel here, and so don't worry, all this is, it's still getting blood flow, it's just not seen on this picture because all the blood is preferentially going this way. So that patient went to rehabilitation here at Silver, RIC, and 2 weeks later went home with no residual trauma. So went to work, did very well. Found an underlying cause in that case of an abnormality in the heart, a little hole in the heart. Sometimes a hole in the heart can lead to blood clots, or it can allow blood clots to go through it, which can go up in the brain and cause stroke. So that's a case of an ischemic stroke. That's a case of a stroke that is due to a blood clot that's cutting off blood flow from the area. Now we'll look at another sort of stroke. Now we'll look at a hemorrhagic stroke. I think I'm making the videographer's job more difficult by walking around. Maybe I'll stand back here and look forward.
That's fine.
That way you can always hear me. All right, got it right here. Hemorrhagic stroke. So this is different. So there was a white splotch, much bigger than a tiny little white splotch. That white splotch we saw before was a thrombus. It was a clot. In this case, this is active bleeding into the right side of the brain. And one of the things that you can see if you look at this. If you look at this picture, there's sort of a center of the brain. You can maybe see a little line here. Center of the brain lined up through there. It's important that the center be in the center. Unfortunately, with this particular case, the center, which should be right about here, is moved over. So this big gob of blood pushing the center of the brain over, pushing all these structures, damaging all of this area, potentially. Certainly having a lot of what we call mass effect, or pushing over. That was one kind of hemorrhage. These are hypertensive hemorrhage, we call it intracranial hemorrhage. Happens sometimes just from high blood pressure, sometimes from medications like Coumadin or aspirin or Plavix in very rare situations. Another kind of bleed that can happen happens from a ruptured aneurysm. So this is an example of that. There's blood in the spaces around the brain because there's blood vessels in here and aneurysm ruptured. Sort of not terribly dissimilar from the patient that I was just taking care of that delayed me. So there's bleeding here in the spaces from an aneurysm. Is that going to work?
No.
Okay. Okay.
I can get you one if you'd like.
What's that?
I can get you one.
Yeah, we should probably show them all. So they come all this way and they waited like hours for me, so we should show them good graphics. Okay, I'll keep going. Let's see. So why don't I talk about, I'll get distracted by this. Let's talk about coiling. So when you have an aneurysm, it's generally a sort of a sac, a bulge on the side of a blood vessel. And then the tip of that aneurysm has burst, which led to the bleeding. This is much less common than ischemic strokes in the first one I showed. It's less common than the second kind that I showed, the bleeding to the side of the brain as well. But this bleeding sort of around the brain from an aneurysm, something can be quite devastating as well. And you have these blebs, outpouchings on the side of the blood vessel walls. And the nice thing is that it used to be we had to crack open the skull and have a neurosurgeon come in and put a clip, put a little clothespin essentially, a paper clip, across the neck of the aneurysm to pinch it off, to close off this outpouching. But in the last 15, 20 years, I have a new technique, which actually fill it from the inside. So instead of taking off the skull, we just go from the inside, the same way again. I mentioned the cerebral angiogram, just like a cardiac catheterization. A small needle is placed in the groin, in an artery here. Turns out every artery in the body connects to every other one. And so by putting a tiny little tube through that needle into the artery, you can wind your way along into the arteries up in the brain. And if there is an aneurysm, if there's an outpouching of one of those arteries, you can in fact drive right into it. We have machines like this. You lay flat, there's a camera that goes all around, and it sort of takes x-ray pictures. And just as with the angiogram, we inject dye, and we can subtract off the skull and the skin and the rest of that, and just see the blood vessel, we can do the same thing, and we can potentially see an aneurysm, an outpouching. And we drive right into that outpouching, and we pack it from the inside. So we close off the hole from the inside of it. Kind of the difference between I suppose putting a patch on something from the outside and sealing it off from the inside. So here's pictures of the blood vessels that we're driving up into. Yep, and there's the outpouching on the side of the wall. There's the outpouching. This is a normal vessel. It should just be like this. This is one of the little tubes that we drive up in. You have to take several of them in increasing size. I'm going to guess that they're going to do something a little funny here in order to make this work. Eventually they'll drive up into here in just a second. Oh, sorry, I'm putting the stent up first. Okay, so sometimes you have to put these stents up to keep the coils that you use from falling back in. And then you'll see they drove up into this aneurysm. And then we're going to put these coils in. We're going to fill this aneurysm with little platinum wire coils. I kind of think of it the same way as the hair in your shower drain closes up your shower drain so it backs up. These little hairs of metal fill this so that no blood can get through. The other thing is they act as a scaffolding, almost like rebar in concrete, and they allow the blood to clot around there and to sort of seal off the plug. This part of the vessel is wide open, a nice stent that keeps these coils from coming into the vessel, and so then you just seal off this bit. And you can see they're putting more and more and more, and you keep putting more and more and more until it's as sealed off as you can possibly make it. And that's how the coil makes. That's the idea of coiling, with, in that case, with a little bit of stenting as well. So here's a typical case of subarachnoid hemorrhage. A young lady who was brought to the emergency room and had sudden onset of headaches. It's usually sort of worst, I would say the worst headache of your life. It's the classic thing. Thunderclap headache, comes out of nowhere oftentimes. She also had seizures, so sometimes any of these things, any kind of stroke, can potentially lead to seizures. That's abnormal movements of the body, uncontrolled, because the brain is being stimulated. So in this particular case, she was brought to Silver Cross. A CAT scan was done, which showed subarachnoid hemorrhage. And both the Neuro Interventional team and the neurosurgery teams were consulted. A drain was placed to drain the fluid. I may have a picture of that, we'll see. But this is another CAT scan showing us a classic pattern of subarachnoid hemorrhage. It's in the spaces that the blood vessels go in, rather than sort of being in the brain itself, it's in the spaces. It's called the subarachnoid space. So it always kind of looks like this. These are the fluid-filled spaces in the brain. And because I've been looking at these for more than a decade, I know they're larger than they should be, so that's probably why they put the drain in to help drain the fluid out of these spaces which are backing up. So they did an angiogram. This is a different blood vessel. The blood vessels we saw before were blood vessels in the front of the head. This is a blood vessel in the back of the head. And as you follow up the angiogram picture, splits here, but something isn't quite right there. There's a bulging out. And if you look at, you can actually take fancy views of this. And we can take the picture and take it from multiple different angles and then reconstruct a three-dimensional view. Something like this. This one, it looks like it just is stationary, but we actually can spin them around and move them and manipulate them in 3 dimensions, and so get the best possible picture of this little aneurysm right here. So then what they did was drive up into that aneurysm, like the video we saw last, and put all these little coils in there. You can see how it's now not feeling quite the same way that it was. We don't always pack it completely. It's not always totally firm. But we do the best we can to exclude the blood as much as possible and keep it from bleeding out the top. So this patient also recovered at Silver Cross. We watched for all the different things that can happen from subarachnoid hemorrhage. The fluid buildup I mentioned. There are other things that can happen. Spasming of the blood vessels in the 4 to 7 to 10 days after the bleeding. So we watch people carefully in the ICU, sometimes for up to 2 weeks. But eventually this patient was discharged to RIC and again went home with no residual symptoms. So the video kind of went through the takeaways as far as what are the signs and symptoms of stroke. Some of them, there's a couple different ways of looking at it. So really sudden is the key thing. Strokes tend not to come on gradually over days or months or weeks. They tend to come over in minutes or seconds. We go from having no headache to having a headache, or having full strength to having bad weakness. These are sudden, and whether it's weakness, whether it's numbness, whether it's trouble seeing, whether it's headache, whether it is trouble walking, trouble talking, these sudden onset of these sorts of things can often be some sort of stroke. So it's important to look for sudden numbness or weakness, face, arm, or leg, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one or both eyes, sudden trouble walking, or have a lack of balance, or sudden severe headache. And as the video showed, and some of the public service announcements do, we ask people at home to check fast, face, arms each time. So we ask the person to smile, see whether one side droops or not. You can raise both arms and see if one side goes down or whether the one side won't go up at all. And have them repeat a simple sentence. No ifs, ands, or buts, or the cat went upstairs. See if they can repeat properly. That checks the understanding, that checks the generation of speech. And the time is the key thing. So if somebody has any of these symptoms, time is very important. If they have an ischemic stroke and there's a blood vessel blocked off, every minute that goes by is another minute that that part of the brain is not getting blood flow and is more and more likely they'll be permanently damaged. On the other hand, if there's leaking, if there's rupture of a blood vessel in the brain or an aneurysm, there's more and more blood that's pouring out every minute that goes by. So it's very important to get to the hospital right away. And unfortunately, unlike my colleagues in cardiology, when the patients have chest pains, and I have an elephant sitting in my chest, very few people say, all right, I'm going to sit at home with my elephant. No, everybody goes to the hospital. On the other hand, somebody who can't move their arm, they say, well, maybe just fell asleep, this is nothing, I'll see what happens. And 6 hours later, the next day when the family comes over, then they come to the hospital. And by that time, the damage is done. There are things that we need to do at that point still, but a lot of our options are reduced. So I don't know what my colleagues have covered. I'm happy to cover any questions. I've been doing stroke, as I say, for more than 10 years, covering both ischemic strokes as well as hemorrhages, and now take care of subarachnoid hemorrhages, aneurysms and rupture, do surgeries on the carotid arteries as well as aneurysms and malformations in the brain. So I'm happy to sort of answer questions, go through cases. If there's things you guys want to talk about, I'm happy to talk about that.
What's the difference between they call it small strokes, multiple strokes?
Well, so the thing that comes up the most is something called a transient ischemic attack, or sometimes called a mini stroke. This is something that stroke neurologists and folks have been trying to stamp out of people's vocabulary for a while. So transient ischemic attacks and strokes, they're basically different versions of the same thing. It's not necessarily that one's smaller in size, the idea is the same. When somebody has a transient ischemic attack, blood flow to an area of the brain has been reduced or cut off altogether, but then it has been restored. And there are many reasons why that might happen. A blood clot might lodge and cut off blood flow, but then the body has its own anti-clotting thing. It can eat away at the clot and break up itself sometimes. That's one reason that might happen. So somebody has symptoms, there's a blood clot that forms, and they can't move their arm, or they can't talk, whatever it might be. And part of their brain is starving for oxygen, starving for fuel, so it doesn't function, it doesn't work. So they have the weakness, they have the trouble speaking, whatever it might be. But just the same way as, if you put somebody's head underwater, playing with your little brother in the pool or something like that, your little brother can hold his breath for a little while. So you can put that head underwater and he won't like it, but he'll be fine once you restore oxygen, once you get him up out of the water and he takes a breath. Same thing with the brain. If the blood flow is cut off for a short period of time and you restore it, everything will go back to the way it was. And that's generally what happens when somebody has a transient ischemic attack. So blood flow is cut off, function is lost temporarily, but the body reestablishes flow, everything goes back to normal, there isn't any damage. However, just the same way as if you leave the little brother under the water for 15 minutes, it doesn't matter whether you lift him up after that point. If the clot is there for long enough, that part of the brain dies, and it's not going to come back. That's why speed is so important. The difference between a stroke and a TIA, essentially, is whether there is recovery, whether there is damage. You say a mini stroke, you say a transient ischemic attack, that there hasn't been any damage because it wasn't long enough, it wasn't bad enough. But whoever that person is has just had a blood clot that blocked off flow. What's to say the next time it won't stay there? Let's say the next time the body won't be able to break it up and they won't have a stroke. So we consider that an emergency. If somebody has an episode and it goes away, I want them to come right to the hospital. We're going to look for the source of that blood clot. We're going to look at the arteries. We're going to look in the heart. We're going to look in the head with all the various techniques that we have. Try to find out why that blood clot happened. Give medications, make changes so that no more blood clots happen. Because in the first couple of days after TIA, there's a dramatically increased risk of having full-blown stroke. So So the person who has the right arm weakness that goes away, they'll say, oh, I'll call my doctor next week. They have a much higher chance in those first couple of days of having a stroke to be permanent. And so it's, again, very important to see a doctor, but really in that case, go to the emergency room, get seen right away. I don't know that I answered your question. You talked about sort of multiple strokes. So there are different reasons people have strokes. I don't think Dr. Shownkeen went through any of that, but sometimes one particular artery gets build up of plaque, and so that one particular artery can clog off, and you can lose blood flow to one particular part of the brain, and cause sort of a stroke in an area. On the other hand, sometimes many different blood clots form, or one blood clot forms and it breaks up, and like buckshot, they all go to different parts of the brain, so you can have lots of strokes in multiple different areas, multiple strokes simultaneously. That often comes from a blood clot in the heart, although it can come from other things. So that's sort of the reason why somebody might have a sort of single stroke versus multiple strokes in the same time.
What if you have no symptoms?
So it is possible to have very small strokes and not even know it. So it's a little bit different than what we think of as strokes. But people, especially people who smoke, who have high blood pressure, who have diabetes, who have high cholesterol, can have tiny little strokes that are so small that they're not even aware of it, but then they build up over time. And they lead to, actually, they can lead to dementia over time. They can lead to, oftentimes they eventually will lead to a bigger stroke. But that's why it's very important to make sure that blood pressure is controlled, that diabetes is controlled, that cholesterol is controlled. I don't think that little silent strokes are something to worry about if you don't have high blood pressure, don't have diabetes, don't smoke, don't have high cholesterol, don't have a family history. We shouldn't be worried that that's something that's going wrong. But if you have any of those things, and especially if you're not well controlled, you could be having tiny little strokes that are silent. But the best thing to do with those is to treat the underlying problems, treat the high blood pressure, treat the diabetes, treat the cholesterol, treat and stop smoking. You can't do anything about your family history. But treat the disease you have as best you can.
Dr. Burgess,
Yeah.
do people mind if I ask you for a second opinion? Okay, our daughter's 60 years old.
Yeah.
At the end of July, she had a stroke at home by herself, laid on the floor 4 days before she was found.
Yeah.
And when they picked her up, she had bled. And it was on the floor. When they picked her up, her heart on the floor, her skin stuck to it, so she had a red sore before we decided to football. Here's the question. My question is this. She can talk. Her grammar is perfect. I'm her mother, and I feel so inadequate when I'm talking to her because she knows all the right words to say everything.
Sure.
I know.
Yeah.
Very bright. However, she's paralyzed on the left side all the way down.
Sure.
And she's in pain constantly. When they put her in a wheelchair, she can't even sit up. I don't know, I think they tie her up maybe to keep her from falling out. And the pain is so terrible. My question is, will she ever be better?
So let's see, how long has it been?
3.5 months. Wait a minute. Yeah, 3.5 months.
So recovery from stroke and the rehabilitation portion of stroke is critical. That's why we have colleagues at the Rehab Institute of Chicago and others. All of the fancy things that you saw pictures of that people were talking about in the video and what have you are wonderful, but it really turns out that there's a certain point that the stroke is what it is. You work on preventing another one, you work on figuring out why it happened, but once the stroke has happened, then you need to try to maximize somebody's recovery. And that really depends on the individual stroke, what the details of it are. But we know that to activate parts of the brain that haven't been affected, to try to help have those parts of the brain that haven't been affected help out, perhaps take over some of the functions of the brain that was damaged. That can happen only incompletely and not perfectly. But you can try, and the best way to do that is just like learning to do anything. You kind of have to teach a new part of the brain to do a new trick. Just the same way as you learn to hit a baseball or a golf ball or learn to read or what have you. The only way you do that is by practice. And so that's why rehabilitation, physical therapy, occupational therapy, speech therapy, for whatever the deficits may be, are important to try to maximize the recovery. For young people, and you said she's 60-some, that certainly falls into the young category as far as I'm concerned. For young people, they recover better than older people, but bigger strokes recover slower and worse than smaller strokes. And when people can't move at all, when we say paralyzed, she can't move at all. What do you think at all?
Not on the left side.
Not on the left side, yeah.
The right
And
side
when
is
you
good.
can't move anything on whichever side is affected, that's a lot harder to come back from than if there's a lot of weakness, but there's trace movement. But if there isn't, regardless, you do the same sort of things. You maximize the rehabilitation. And 3 months is way too early to say much. Really, that recovery that happens can occur lifelong. We think that most of it happens in the first year or two, but certainly not in the first 3 months. So there is still, there's reason for hope. The fact that she can't move it at all puts her in a bad category, no question about it. But there is hope. She's young, and it's only been a few months, and so certainly you want to continue to do all the things that you can do to maximize that recovery.
And she's very determined.
Yeah.
She constantly tries to wiggle her toes and her hands.
Yeah.
She's a member of Mensa.
Yeah.
She's always
She's
just,
right or left-handed.
she's right-handed.
You know, she can write and she can talk and she can listen and she can understand and do the best things she can with therapy to get some work back on the left side. She probably will never be normal on that left side.
No, I know she will never be normal, but if she could just be better, if she could just get to where she could sit in a wheelchair and, you know, she's got a good education.
Sure.
If she would just be out of pain.
Yeah. And the pain is so that one, again, another important reason to talk to not just the therapist, physical, occupational, speech therapy, but they're also physical medicine rehabilitation, also known as physiatry doctors, rehab doctors, who are expert at making sure that the tendons aren't shortening or the joint isn't getting crushed or the positioning isn't right. There's lots of things that can lead to that sort of pain that are mechanical, that have to do with the fact that she's no longer moving it and all that. It can, the muscles and the tendons and everything can shrink up and joints can get frozen and that can hurt. It's also possible for the brain to cause that pain, less common, and I don't know exactly in her particular case, but very reasonable if she's not seeing a PM&R rehabilitation physiatry doctor to do that. That would be a person to try to optimize these things. Yeah.
Thank you.
You're quite welcome.
Thank you. I'm glad I came.
Well, again, I apologize for the delay, as I say, it's sort of emergency surgery, but really heartened that all you guys came out, and I don't want to keep you too much longer. If people have additional questions, I'm happy to answer them now, either in the group or up here personally.
What was the name of the doctor?
What's that?
What was the name of the man that spoke in the green
That was
outfit?
Dr. Shownkeen. Dr. Shownkeen, Shownkeen. Yeah.
His partner.
Right, he's my partner, so.
Well, you
Yeah.
guys,
Yeah.
I'm just glad you're alive and doing what you're doing. It gives me hope for my daughter.
Thank you.